Our speakers for today are Dr. Patel, Dr. John, and Linda Hardy, and they'll do an introduction, and then we'll do a shared screen, and you'll see our PowerPoint. So if you just want to take a couple minutes.
Hi, Kilol Patel. I'm one of the lung docs over here at Saint Barnabas, and we'll go over all your questions and concerns you might have regarding asthma and COVID, and we'll go from there, basically, on how it goes.
Hi, I'm Miriam John. I'm one of the ED docs. I've probably seen a bunch of you as you roll through the ED, and we'll go over the slides and take questions.
I'm Linda Hardy. I'm a licensed respiratory therapist and asthma educator, and we are going to go through all the slides today. You sent in about 10 questions, which we'll answer specifically, and then we'll open the floor also to any other questions you may have. So welcome everyone, Milburn Fire Department, First Aid Squad, Summit Fire Department, Maplewood Fire Department, and Springfield Fire Department. We're glad to have you here today. So we already did introductions. Now you can kind of put a face with the name. Myself, Linda Hardy, Dr. Miriam John, and Dr. Kilol Patel. Can you hear us okay?
Yes.
So today we're going to talk about symptom screening, help stop the spread, specifically talk about events and gatherings. A lot of us are starting to venture out now, so we want to talk about that. The CDC guidance on the at-risk groups. Specifically, we're going to talk about COVID versus cold, flu, and allergies. Very important going into the flu season, and a lot of people have questions on that. We're also going to discuss COVID versus like asthma and COPD symptoms, and as you see patients like that as well, and also for you and your family members. And then we do have 10 questions that were sent in prior that we will answer, and then any other additional questions. So we'll be here till about 1 o'clock. So the symptom screening, I'm sure you are also doing in your places of employment. It's really the temperature screening is done, and questions are asked too. Have you had any shortness of breath or a cough or chills? Have you had shaking with chills, a sore throat, any body aches, headaches, nausea, a new loss of taste or smell? So those are the things that, again, are the typical questions you're asking for. Not everyone's going to have all of these things. They might just have one or two. Sometimes none, and that's why they're asymptomatic. So around here in the facility, and especially when you're out and about, you want to wear a face mask at all times. You want to also practice your hand hygiene before you put the mask on. When you remove the mask, when you come in, you're touching doorknobs, you're touching different things. So frequent hand hygiene is very important. And then at least maintain the 6-foot distance of others. Right now we can't do that, so we're wearing the mask. Which is again going to stop the droplets that come out as we speak. So all of those things together are helping to protect not only you but those around you, which is important for a lot of you that are, when you're at the firehouse and you're living in that environment, to practice those best practices as well. So help stop the spread, we talked about that. Keeping that 6 foot of distance, again, that's very important. When you're relaxed, you're in your home environment, still if you can keep that distance for the fact that the droplets usually travel about 3 feet and then fall to the ground. If you can't keep that distance, keep your mask. If you sneeze or blow your nose, if you take your mask off, obviously don't sneeze into the room. Have the tissue ready or sneeze into your mask, get rid of it, and get a clean mask. Wash your hands, obviously, we talked about before and after putting the mask on. When you take off your mask, make sure you're taking it from the loops, you're not grabbing it at the face. And also clean and disinfect surfaces. Again, high-touch surfaces, your phone, doorknobs, toilet handles, tops of tables, backs of chairs, anything, again, that's very high touch. And then again, washing your hands for at least 20 seconds, or if you're using hand sanitizer, 30 seconds, make sure you're going in between the tops of the fingers, around the thumbs, use your nails on your palms, make sure it dries. So again, hand washing first, if not the hand sanitizer. Anything else you want to add? Okay. So this is a big one, events and gatherings. You know, if you're thinking about attending something, obviously we have the lowest risk form right now, a virtual event and gatherings, and people have been doing that a lot with Zoom with their family members and new babies being born and with grandparents and things like that. But people now are starting to venture out to more risk, sort of those smaller outdoor in-person gatherings. We're going to have a barbecue outside. We're going to all be 6 feet apart. But still, you might cross each other going in and out of the house to use the restroom. So wearing the face covering is necessary as well. And then not sharing objects, and then making sure that they're coming from the same local community. You've probably all heard the stories about a family that traveled to a wedding in South Carolina, came back up and infected. So again, you want to keep in your local community or town. Just remember, everyone you're coming into contact with, you're coming into contact with who they came into contact with as well. So if you have a household that has any kind of risk factors, you have to think about that as well. Next slide. Higher risk. So that's when you get to these medium-sized gatherings. There's going to be more people. You're going from 10 people to 25 people. It's more risk. And again, you're going to do all the same things. Maintain 6 feet apart. Keep people from the local area. Wear your mask. But again, if you have any underlying health conditions or any of your family members, you can avoid those. And again, they should be outside.
Yeah, I think indoor gatherings are definitely higher risk than outdoor gatherings.
Yeah. And then the highest risk is, of course, large in-person gatherings. You know, try not to do any of that. I mean, in this day, right now, I mean, if there's really not a reason to do it, it's just really difficult to maintain the space. You've all seen it on the news. It's just very hard. And of course, this would include people that are traveling from outside areas. So if you have family members that are coming up from Florida, they got to quarantine for 2 weeks. There's a list of states that need to quarantine. You don't want to be at this point with everything that's going on with the rest of the country. It took us so long to get our area under control. You don't want to invite someone that's traveled outside into your event or gathering at this point. So, Dr. Patel, maybe you want to talk to the CDC guidance about people with underlying medical conditions and what you've both been saying.
So the main medical conditions on which people can actually get worse or get severe form of the disease are people who have chronic kidney disease, any kind of respiratory illness like COPD, asthma, pulmonary fibrosis. Diabetes is one of them. Obesity, obese people, even young people who are pre-diabetic but are obese, we have seen that they get actually quite severe disease during the outbreak when we had it, at least at our institution. Anytime you have a liver disease, any kind of cancers, smoking history, and children and adults, like I've just read up about this because I'm an adult physician, but in children, they have said that people who have had developmental delays and some kind of
the chronically ill kids
are the ones who are more
at risk.
susceptible for it. And immunocompromised states, so anybody who has cancer, who are on immunotherapy or any kind of organ transplant and are on immunosuppression medications, or for any reason they're taking chronic corticosteroids or any kind of other biologics that would suppress their immune system, those people are at increased risk to get severe disease. This slide is actually a pretty decent slide. This slide goes over the differences between COVID-19, cold and flu, and seasonal allergies, because it's very hard to differentiate and tease them out, right? So in the length of symptoms, whenever you think about it, seasonal allergies, usually it lasts several weeks, whereas flu can be from 7 to 14 days, usually by 10 days it's gone. Cold is also less than 14 days, whereas COVID can continue as often long as like 2 or 3 weeks or more. It can even be asymptomatic. Cough is present in almost all of them other than seasonal allergies, in which you have more of a runny nose and watery eyes kind of symptoms. Shortness of breath is only present in COVID. It's now, you don't get short of breath when you have a cold, flu, or seasonal allergies. So sneezing is uncommon in COVID-19, whereas it's fairly common in seasonal allergies and cold. Flu also doesn't give you any kind of sneezing per se. Runny nose also is more common in the allergic kind per se. Sometimes in flu, but in cold you can get the runny or stuffy nose. Sore throat can be present in all four, however, it's more common in cold. Fever is common in COVID, cold, and flu, but not in seasonal allergies, whereas feeling tired and weak is present almost in all of them, but rarely in seasonal allergies, but more in the other ones. In flu, it's always there. Headaches can sometimes be present in COVID-19, it's rare in cold. In flu, it is very common, and sometimes in seasonal allergies. Sometimes you can get something called a sinus headache from it. If your sinuses get clogged up with thick mucus, and you can get headaches from that. That could be from the seasonal allergies. Body aches are fairly common in flu and cold, and sometimes in COVID-19, but not that much in seasonal allergies. There are diarrhea, as you might have heard, like loss of taste, smell, and diarrhea can happen in COVID-19. In a few people, it's not present in cold, it's not present in seasonal allergy, sometimes flu, certain children can present with that. Chills are present sometimes in COVID-19, not there in cold, not there in seasonal allergies, and sometimes in flu. And loss of taste and smell is as I mentioned earlier.
So stay on the slide. So would you talk a little bit about, it seems like the most is similar as COVID and the flu.
Yes.
Right. So maybe talk a little bit more about how
How to-
people.
Yeah,
Yeah.
so usually whenever you approach it, you should approach it as if the patient has COVID-19 per se. But whenever you think about it, shortness of breath will be present mainly in COVID-19 and not that much with flu per se.
Right.
Usually you have some kind of an exposure with that. It starts off with myalgias, chills, and high-grade fevers with that in the flu season. Whereas in COVID-19, usually that doesn't have to be the case. It's like a slower onset. The peak is a little bit on the slower side, whereas in flu, the peak is way quicker. It's quick on, quick off, kind of like within 10 to 14 days, you're off from that part per se. And that's the most important thing. That's what I would think of per se, unless you want to add something.
I think fever and cough you're going to
Yeah.
probably have in both cases,
Both cases,
and you're not going to be able to tell the difference. But
Yeah.
shortness of breath you really shouldn't be seeing with flu.
that
It really
one,
should
yeah.
be, if
Only
somebody's short of breath, you really should be thinking COVID-19.
Yeah, but none of the other three.
And then obviously the first thing you're going to do is call your healthcare provider.
Yes.
If you have those symptoms, that's the first thing. And they're going to advise you on what to do next, whether it's go to the emergency room, whether it's go to get COVID tested.
Yeah.
It's really going to depend on, you're going to have probably a virtual visit like we're doing now so that the doctor can.
Screen you through that
Right.
and then go from there. Basically,
Yeah.
that would be the usual practice right now.
And what about flu vaccines?
About the flu vaccine, it's actually even more important. So we are just looking it up. We are having a discussion prior to this meeting saying, what's the usual number of people, how many people get the flu vaccine every year? CDC reported like in 2018, only 37% of people got the flu vaccine.
Wow.
And the number was about
It was 60%.
60% in people who are 65 and older were getting 60% of them had the vaccine. Still, it's fairly low. The problem, what all people around the world are afraid of, is when we hit flu season, we could have a double whammy, meaning your immune system is already brought down by the flu, and on top of that, you get the COVID-19, and it could be really, really hard for your body per se. You can get very severe disease from that. So it's recommended that everybody should get the flu vaccine, and just doesn't mean that only you guys should, even your family members should get it. Like, it should be universal, not just selected group of people who are getting exposed, because you come home to that. And that's very, very important. We need to bring up those numbers very high. Yes, there is some reluctance about flu vaccines throughout history, per se, because it's based on a statistical model, right? To predict what kind of flu strains are going to be at higher risk during this season, and that's what is encompassed in the vaccine, and that's how we get it. But most of the times it's fairly effective, and even there is good data to support that if you get flu vaccines year over year, you maintain serial antibodies, and that can help you out and train your immune system into protecting yourself. So there's fairly good data about it. If people who are interested, and if you have Netflix, you should look up Pandemic. That's a fairly good documentary on it, and it talks fairly in good detail about it too. But yeah.
So yeah, very important for yourselves. Encourage your family, encourage your friends to get the flu vaccine. Absolutely. And then again, there's so many resources out there. The CDC, the World Health Organization. This slide happens to be from the Allergy and Asthma Network. Just again, sometimes it's good to look things up. Educate yourself, and just things are constantly changing. So just keep aware of what's happening, but do all the best practices.
Be diligent.
Yeah. So this one is could it be viral? And this is really for the schools, but it could be applied to anyone, because it goes back to is it COVID-19? Is it the flu? Is it asthma? Is it COPD? And so this is just a decision tree that kind of goes through what we've been talking about. Is there a fever? Is there a cough? Is there nasal congestion? Are they having basic fatigue, a loss of appetite? So it really is just helping the healthcare providers, or again, if you're looking for a family member to kind of decide if your child does have asthma, how would you know the difference? Usually asthma is going to have some wheezing associated with it, could have some shortness of breath associated with it, but you're not going to have a fever. You're not going to have some of these other symptoms that you have with the flu or with COVID. So this is really just talking about, again, everyone screens the same way, asks the same questions, and then you're always doing your regular maintenance medications. So this is not the time to decide you're going to sort of not take your medications regularly or to forget. This is the time to be very diligent, to make sure you set phone timers if you have children that are asthmatic or adults that have COPD, that remember to take their medications, make sure they're taking their corticosteroids, doing all of that, so that, again, you can answer, well, we're doing everything that we normally do, but I'm still having these symptoms, because you don't want to have shortness of breath and start thinking it's COVID, when it's really you're exacerbating because you're not taking your meds. So this slide is just talking about the multi-system inflammatory syndrome in children, which we haven't seen a lot of.
It's more of it's a delayed presentation rather than the initial. So it can happen weeks after being exposed to COVID, and it seems to be more of a syndrome just in children. So they can have. So you should think about it. It's if you have kids who have fever, like a persistent fever, so more than 3 days of fever, and then like the list of associated with typically a rash. It has a lot of similar presentations as like a Kawasaki's disease. You have like a mucous membrane involvement where you're seeing like conjunctivitis. They can have like a swelling, extremity swelling to hands and feet. Some GI symptoms associated with it. Swollen lymph nodes. So all of these things could, make you think that in a child that it could be the multi-system inflammatory syndrome, and that needs further evaluation because there's seems to be some associated cardiac manifestations of it long term.
So again, call your physician as soon as possible, and then again, they'll direct you accordingly whether to bring the child to the emergency room or to the office. Again, they don't delay in calling or reaching out to your physician, and don't play it, well, let's see what happens. Just if they have a fever and they have one of those symptoms that are out of the ordinary, you don't see these symptoms of swelling and things like that, please call the doctor. So we talked a little bit about this asthma and COPD, and really it goes back to doing all the things we talked about. You're wearing a mask when you go out, you're keeping the 6 feet of distance, you're doing hand washing constantly, you're cleaning surfaces. But again, if you're asthma and COPD, and depending on your severity, you should try to limit the time that you go out and what you expose yourself to. If there's someone else that can do grocery shopping for this person or run errands or do that, you really just don't want them to expose because they are at a higher risk. And again, the prevention is also making sure those folks with all kinds of underlying conditions are taking their medicines as prescribed. They're doing their follow-up exams with their doctor. We have telehealth now. There's no reason for people with chronic conditions. They should be meeting regularly with their doctor and not delaying their regular care. And especially for this group, that they get their flu shots. If they're over 65, that they're getting the pneumonia shot. And the pneumonia is a two-prong. If you never had it, there's one pneumonia shot and another one 6 months later, but still getting the first one. It's covered by Medicare. So if you have parents and grandparents and folks that haven't done that, really encourage them to do all these best practices. That's the best thing that you can do. And we have an Asthma Education Center here at the hospital. We're one of 3 in the nation. And basically we work together with your physician to really give you the tools and skills and confidence to self-manage your asthma with your physician. So we talk about triggers and irritants, your controller versus your rescue medications, your asthma action plan. We teach you how to use spacers and peak flows depending on your situation. And then we can also do diagnostic testing, spirometry and pulmonary function tests, pheno testing, different things to help your doctor manage your asthma better. And when you come here to the hospital, I've heard a lot of people say, oh, I don't want to come to the hospital. But, you know, think about, we are on the front lines here. We are going through all the best practices. When anyone comes through the door, they're getting fever, temperature checked, they're been asked the questions. If they're coming for same-day surgery or any other procedures, they're being COVID nasal swab 4 days prior to the procedure. There's so much cleaning going on. We're all masking up. We're all doing the right thing. So you shouldn't put off any of these chronic conditions or learning more, or also, again, getting the tests and things that you need to manage those so that you don't become sick. And so we're through with the presentation now. We're going to go through about 10 questions that came prior to this. So the first question is, where did the virus come from? Was it created in a lab, or was it due to an animal and human interacting?
To go over it, basically, so there are a lot of viruses. Coronavirus by itself is a virus which is found more in animals per se. It's been around forever. And it just transmits, most of the viruses, it transmits from human interaction with them per se. Why we don't get infected most of the times is because the viruses need something called a spike protein on it. That's the protein which will make the virus come and attach to our cells, and that's how we get infected from it. That's why the speculation early on was that, oh, maybe it was bioengineered and somebody attached a spike protein on it and X, Y, and Z, and that's why it happened. The likelihood of that is a little bit on the lower side, or a lot on the lower side per se. There is a lot of primitive data that's coming out per se saying that this virus probably was around for quite a while, but there is some data, for example, that somebody in the United States was infected in December. Sometime there was somebody in France who was way infected, and some in November, December area. So that's way before even Wuhan was spiking up per se, right? The main thing, what happens is viruses mutate. Whenever they mutate, it's like survival of the fittest, right? So it mutates trying to keep itself alive. The perfect virus would be something that doesn't kill off its host per se, and is highly infectious. That's what this is. It doesn't kill off most of its host. That's why you can keep on transmitting it to anyone. And however, it's highly infectious per se. So it will keep on mutating. How scientists look at it is they look at the RNAs, meaning what are they made of. And every time the virus mutates, some of it keeps on changing. And that's ways you can say what's more primitive and how did it evolve. Because you never evolve, like a human won't evolve by losing a leg, right? Like, why would you lose a leg? You need 2 legs to walk. So that way, like whatever the virus mutates into, it will be something that will make it either more infectious or more lethal or X, Y, or Z, meaning adding something to it, not taking away stuff. That's how they can decide what's primitive and what's more advanced and whether it mutated or not. And there are a lot of facilities looking at it. Probably we won't have an answer about the historical, like, how should I put it? Origin and stuff like that based for years to come, because once they map it out, that's the only way we'll probably be able to look into it. But most of the times it is from an interaction. There was recent news about the swine flu thing, like there was a strain which was identified, I don't know, it was most likely in China per se, in which it had the potential to become something like that, but they have things like this. This is not the first time something like that is identified. And if you heard it for the last 5 to 10 years across the world, all the virologists were talking about it, that we are due for a pandemic. They didn't know whether it was going to be a flu pandemic or what kind, but it would be a viral thing. And these happen, and from time to time, it's like probability of some event happening, and it was fairly high. We were due for one. And that's what happens. And the more interactions we have with the flora and fauna, meaning we are doing deforestation around the world, per se, right? All those ecosystems are very protected to begin with. There was no interactions. Our bodies were never exposed to those viruses. So that's why even when we get infected, our bodies don't know what to do with that. And that's why, like the monkey might be okay with it if it's a virus which came from a monkey. However, it probably kills us because we don't know what to do with it, how to kill it, or what happens with it. It's something new per se. So hopefully that answers that question.
So in reality, what is the timeline for a vaccine and how effective will it be?
I mean, I think timelines for vaccines, unfortunately, any vaccine development, you have trials that you have to go through to, see how safe it is to be used on a general population. So you go through like phase 1, phase 2, phase 3 trials where you go from like smaller groups to larger groups where you're testing the vaccine. I think some of that is going to be speeded up for this just because of how impacted we all are. I think right now there's, I don't know, how many vaccines, probably like hundreds, close to 110
trials ongoing right now.
Ongoing, trying to, and I think there's probably going to be hopefully multiple vaccines on the market. Yes.
They're approaching it from various angles, so we'll see. A lot of a traditional vaccine takes at least 2 to 3 years to come through, because they work by inactivating the virus, then infecting you with the virus, and your body builds up your immune system to it. The other things that you hear on the news right now are some of the companies that you hear about is Moderna, or the one with Oxford guys, or AstraZeneca, Pfizer, all of these guys. What they're trying to do to speed it up is something what we call as an mRNA vaccine or an RNA vaccine. So basically, they take the virus's RNA, inject you with it, it forms some kind of proteins, and your bodies can try to fight the proteins and develop an immune system. The whole point is not just making the immune system, like the antibodies or the T cells or whatever they call it, fight, but it should be lasting long enough.
So that your memory cells
exactly. So you can do it and you can fight it off again when it comes back again. It will answer one of the questions that comes lower down, is whether you can be reinfected from the virus or not. So it depends. If the antibodies don't last long enough, then you will be protected from it until you have the antibodies. Once the antibodies are gone, you can be reinfected. And that's basically what it is. So hopefully that answers your question. But yes, we should hopefully see some kind of results. We are hoping for the end of the year, maybe from the RNA vaccines, the traditional ones, hopefully lower down the road. And as we said, that hopefully we'll have multiple candidates. Hopefully they work better.
Yeah.
So.
The next question is, I'm 50 years old, a non-smoker, but I have been fighting fires for over 30 years. I have no known underlying conditions. If I get COVID-19, how bad might it be for me?
So it depends on the comorbid conditions of what we had mentioned earlier.
Right. Yeah. If you don't have underlying conditions, I think your risk is overall lower. I don't think just fighting fires, but if you don't have diagnosed COPD, if you're not a smoker, you don't have chronic bronchitis and obese or diabetes, which we saw was one of the actually very common ones. So I think your symptoms will be milder,
Yes.
statistically speaking.
Statistically speaking, so only, as they said, like about 5% get severe disease,
Right.
and most of them will get a milder disease per se. And even in those 5%, some people will get a more severe or a lethal form of the disease, in which who have those comorbid conditions. So yes, the risk is fairly low, to answer that question in simple words per se. But however, protect yourself.
Yeah.
What is the danger of getting the virus on you and taking it home to your
Yeah.
family? Where on the body can the virus attach itself to?
I think it's, I think it's a, like in the field that we're all in, it's a calculated risk, right? And I think we're all doing what we can to protect ourselves. And what, like as an ED physician, what I do is I'm wearing scrubs to work, and my shoes and everything comes off like the second I hit the door. So I know some people who are getting everything off in their garage and won't even enter their house with anything on. So there's
I do
people.
it before I get to my car, because
Yeah.
I don't want to get my car infected.
Right.
Or
So I think you can kind of adopt any of these strategies. You can do it before the car. You can do it like in your garage, or if you have a space. But if you don't have that, like the first thing when you get home, you're taking everything off and going, not touching anything or anyone, and going right into the shower. And definitely my water bill is high because I'm taking extra long showers. And so, I think that's all you can do to, protect yourself. And definitely the other thing is the things like your phones and other things that you're bringing with you to work. Yeah, cleaning those off, before putting them into your regular bag or whatever. I know a lot of people they do the little like Ziploc bags and they take that out. So I think that's and like people have. I know I haven't been wearing any jewelry. Like no jewelry, no watches, no rings, like nothing.
Try to avoid.
Just try to avoid other things that I need to come home and take off.
And the least amount of stuff you can put on yourself, do that.
The better.
Like you don't need a lot more stuff than what you can get by.
And if you are changing at work, put all your dirty clothes in a bag, a plastic bag, seal it up, so that again, when you bring that into the laundry room, you just are dumping that right into the washer.
Mhm.
You don't even have to touch it again and wash it right away. You don't want someone putting their hands in the bag.
Right.
So and then dump the bag afterwards. So again, just all of those best practices are definitely, we've all been doing them for months and months and months, and I'm sure you guys have been too. So besides wearing a mask, social distancing, and hand washing, what other methods can first responders take to prevent contracting and spreading the disease? So we talked about a lot of these already, and you have all of them. Probably it's the gathering events that you're doing outside of your first responder, because as first responders, you're probably wearing the N95s when you go into interact with people. You assume everyone is positive, basically.
Right.
So you probably have, I don't want to say less exposure, but the prevention is so much higher than you are going to your neighbor's backyard barbecue.
You don't have your guard down, basically.
Yeah.
You have your guard up when you're at work, and when you're outside, you have your guard down. That's when it can probably get you. So keep on maintaining all of these things and all of the things that you do at work, except other than your N95.
Yeah, don't worry about your N95 to
your
the barbecue.
That's not a good.
And it says, what are the recommendations to continue getting tested every month, every other month, 6 months, etc.? So current recommendations
There's no recommendations to continue to get tested, right?
No.
So,
So whenever you get tested, it's somebody who's symptomatic or you highly suspected.
Right.
That's who should be tested. We have our facility is actually doing testing right now, but that's for us, like just to see how many people are infected, or historical or what you call epidemiological data per se, right? That's what it boils down to mainly.
Yeah, unless if you don't have symptoms, really, there's no recommendation to just getting tested, unless you need it for a specific reason for your work, or like travel or something. Yeah.
If you were exposed, then you should be self-quarantining anyway.
Yes.
And just because you were exposed doesn't necessarily mean you're going to test positive either.
Exactly.
You know, so it's I think it's a gray area. There's
still.
Are they seeing any patients previously positive for COVID being infected a second time?
So, quite per se personally. We are just talking about it. So it depends on how you define being infected a second time. Somebody can have a positive test, they're completely asymptomatic now, and you test them again, and they're still positive or they're negative, but the third time they come back as positive. So there's something called, you have to look into it, how these tests are being done. Like, how do you detect the COVID in the first place? It's mainly, most of the places do a nasal swab. You're looking for RNA fragments in it, and then you just do a PCR on them, mainly to, what do you call it? Increase the number of copies of it so you can actually look at it. Amplify, that's the one I'm looking for. But yeah, you amplify it, and that's the way you look at it. Sometimes you can have dead virus in your nose, which is persistent for a prolonged period of time. So you don't know how you can call it reinfection or not. However, at the same token, there's new data which recently came out in the last 2-3 weeks, which said that the antibodies are only lasting for a few months to more than a few months, something like that.
Right.
The current CDC recommendation is, if at all, if you had a coronavirus 3 months back and you are again having symptoms, you should be checked for it. Basically, that's where we are right now. Personally haven't seen anyone, but I have people who are persistently positive over 6 weeks or so, and without symptoms per se.
I haven't seen any reinfection per se, but again, like you said, it's only as good as how long your antibodies are in your body, and if it's only there for a few months, I think that's especially another reason that even, I think people, especially like us in the medical field, if you've had it or tested positive at one point or have antibodies, maybe you're more likely to let your guard down, and I don't think you should. Don't do it. I think you should keep your N95s. Oh, I got infected, I don't need it anymore. No, yes, you do, because you don't know how long any of this lasts for, how long you're protected for. I think all you can do is pretend like you never had it and keep going forward.
The question, are they tracking numbers on first responders, infected, police, fire, and EMS?
So CDC usually has a database on looking at how many healthcare personnel get infected. However, it's run by, if your department or whoever is your supervising thing is reporting the data to CDC. So unless that data is being fed into CDC, nobody would know about it. Like, the data is as good as people feed into it. It's a voluntary thing. It's not a mandatory thing. That's what I think. I might be wrong on that. But usually they use it for flu most of the time, but not, they just started using it, this data per se. I haven't looked at that data yet. I don't know where to look for it, but probably Google would be a but CDC normally would collect data about healthcare personnel. They label it, they don't go into specifics on more
the
about
branches.
branches of whoever,
Affairs, first responders.
but most of the times it's the parent institution, like Barnabas should be looking at us, like whoever your fire, like for the fire department probably should have those numbers per se.
How long does COVID last on surfaces? So I think it's 24 hours for the cardboard. They're saying
hours to days. It's basically
hours to days.
Depends on what it is. So there is good data if you go to BARDA's website, BARDA, there's very good data on it. You can look into it. They even have different scenarios. If you leave it out in the sun, if the temperature goes high this much, how long, and so on and so forth. But as I said, most of this data doesn't show, it only shows that the coronavirus RNA was found on it. Whether it's infectious or not, we don't know. Right. Because nobody, like, as I said, even in the nose, it can last for a couple of weeks, but that dead virus cannot infect you. So we don't know. That's the main thing, but how long will it, you can find it, that's probably for a long time.
And it goes back to cleaning, and I know this probably comes up much more with people buying groceries and things like that. And I just read something, Dr. Fauci says that he waits one day, puts his groceries to the side and just lets them stand there for a day. He washes his hands. Obviously, with fruits and vegetables and all that, you're going to wash them and put them in the refrigerator first. So again, it's all the best practices. And if you want to, put your cereal boxes to the side for 24 hours, then you can do that. So this is the last question, and then we'll take questions. It says, what is the most effective material face cover should be made of? So we're thinking this question is for personal use. And so really, we looked at the World Health Organization. They're recommending a 3-layer mask, the outer layer being water resistant, and an inner layer that's water absorbent, and a middle layer that acts as a filter. Now you can go on Amazon and you can see a lot of masks being sold with filters that are calling 2.5 microns. That is not effective for the COVID virus, because the COVID virus is much smaller. You need a HEPA filter. That's like the filters that are in hospital air conditioning systems. And they do sell them on Amazon. So if you're a person that wants to put the HEPA filter insert in, you can. But remember what the mask is being used for. The mask is to protect others, right? So its effectiveness for protecting you necessarily isn't the same as having an N95.
Yeah.
But if we all wore masks, we'd all protect each other. And it's very also much about the fit. You'll see people walking around with the mask not covering their nose. That's not wearing a mask.
Like my biggest pet peeve.
So that's the kind of thing, again, that I can understand why you want your own mask to try to protect you from the outliers that aren't really using their mask correctly. So that's some of the things. 3-layer. If you want to get a insert, make sure it's a HEPA insert. And the other thing is, when you take off your mask, don't touch the middle of it. Use the ear loops, excuse me, and then wash it. They need to be washed. And you can go to the EPA and look for, again, the concentration of bleach to water, or if you want to use other clean materials that you have in your home, they'll tell which ones are rated to kill the COVID virus. So there's lots of resources out for that. And like I said, it's a 3-layer mask.
And OSHA has also pretty good stuff about it. Divides it into if you're low risk, medium risk, or high risk. Meaning if you're working as a dispatcher per se, you're not coming in contact with anyone or anything like that. So you're in your own cocoon per se, so you're in a low risk group. Medium risk would be you are coming into interactions with people that much. High risk would be the people who are actually going out to get the sick people in. So the high risk people should always be wearing N95s when they are working per se. When you're off work, probably, as Linda was mentioning, depends on what you want to use and for what purpose you're doing it for. But overall, everybody should be wearing some kind of a mask.